To begin with, tip number 1, radiographs are a must for endodontic diagnosis. So you should only conclude with a diagnosis after you have done your radiograph and done your interpretation. If you don't have x-rays, then there is no endo. Tip 2 is to go digital. There are numerous reasons to go digital. Well, these are the 3 popular reasons. One is because we want to lower the radiation doses for our patients. Second, we want more clearer images because we want better image quality in order to interpret radiographs. And third is for the storage. It's easier to store digital x-rays than your regular films in your clinic. The next step is to take multiple angulation radiographs whenever needed. If you look closely at this picture, you can see there is an x-ray of a premolar. You look closely at the apex, it looks like there is a periapical infection, but when you take an angulated x-ray, that's the second following the second x-ray, clearly shows that that radiolucent area moves away from the apex, and it's very clear that it's the mental foramen and not radiopathological lesion involving the root of that tooth. Tip number 4 is to use a position indicating device. For me, all my x-rays are done only with position indicating devices. Reason because an ideal x-ray should cover the entire tooth and also structures around the tooth. And second, you want to have good cone angulation. You don't want elongated x-rays or shortened x-rays or a half cut, cone cut x-rays and these kind of things. So this is the position indicating device that I use for my regular radiographs, periapical radiographs and my Bitewings in the clinic. You can see this picture. The one on the left shows an x-ray, a diagnostic x-ray without the use of position indicating device. Clearly shows it's a little elongated and the tooth of interest is more to the side, and there is a cone cut. The one on the right side clearly shows the tooth, surrounding structures, good angulation. This was taken using a position indicating device. So it's very important when you take x-rays, you are going to hand over these x-rays to your patient when they walk out of the clinic. So it is your reputation, because if this patient is going to carry this x-ray, go to another clinic, and if another practitioner is going to look at this x-ray, probably for a second opinion, you want to make sure that your x-rays are proper. Tip number 5, take Bitewing radiographs whenever needed. If you talk about pre-treatment assessment, I would do Bitewings if I want to assess proximal decay, and also when patient has a deep distal or mesial caries and is very close to the nerve, and I want to know if there is pulpal involvement or not, I prefer to take Bitewings. And post-treatment, I use it to evaluate my post-endodontic restorations or my regular restorations. I'm talking about proximal restorations, just to make sure I don't have overhangs or underfills or voids or spaces at the gingival seat area. You can see this is an x-ray of my patient. Patient came in, you see the periapical clearly shows that there is a deep distal decay, restored tooth, and the secondary caries looks very close to the nerve. So this shows a little bit of dentin present between the nerve and the x-ray. So it gives you a picture as if there is some amount of dentin. So you are thinking restorative part of, or you're looking towards doing a restorative treatment plan. Whereas when you take the Bitewing, clearly shows, you look at that, it clearly shows that the patient has caries involving the nerve. So you want to change your concepts. You probably start looking from the endo point of view. Okay, and cube shift x-rays important because you want to, this is also very common. Some call it the Clark's rule or the buccal object rule. SLOB, same lingual, opposite buccal. Let's not go too much into it. Okay, why do we need to do this? Because you want to identify, for example, you want to know if a case like this, the patient has a failed root canal and you suspect a missed canal, and then you want to know which canal is missed. I do a mesial cone shift, and then clearly I can see that the buccal canal is the one that is missed, and I know I can go in and retreat this tooth. So SLOB technique is very useful in these kind of situations. What about the next tip? The tip on using cone beam CT scans. I highly recommend you use small volume CBCTs for your endodontic diagnosis or your treatment planning or all these purposes. In case you have complex root anatomy, CBCTs will really help you. And also to assess the proximity of vital structures. You have a huge lesion, you have the inferior dental canal, you want to know if you're already there, or if there is an infection in the maxillary sinus from an endodontic origin. There's so many other reasons, like these. So CBCTs really come in handy. If you look at this, I like to use them for both my diagnostic purpose, also my treatment purpose. Look at this X-ray, clearly shows that the right maxillary first molar was a tooth of complaint, and my radiograph shows that the previously done endo, the buccal root was well short of the apex. When I get a CBCT done, look at that, shows a lesion. This is not very clear in my periapical X-ray. The CBCT has helped me identify the infection. Easy for me to put forward this to my patient and convince them that they need to do a retreatment, and it's evidence you can put forward to your patient and they do understand. Okay, tip number 8, use radiographic tools. Most of us have digital X-rays in our clinic, but how many of us actually use the tools that are there? Numerous ways you can use it. I'm just highlight 2. One is the measurement. You can measure the size of the lesion in case you want to compare it post-operative, or you want to plan whether you want to do a non-surgical or a surgical treatment plan. In terms of endodontics, you want to see the size of lesion, you can always use the tool to measure. Sometimes the X-rays are not very clear, very difficult to identify root apices or how the quality of your obturation. You can also use the inverted images, it kind of helps. And tip number 9, treatment follow-up is best when done with radiographic comparisons. Always compare. Don't go with patients with pain, asymptomatic is success. No. Sometimes the lesion could be getting bigger in size, the patient could be asymptomatic. So don't go with that. Always you should see periapical bone healing. This is only possible if you compare your pre-operative with your 6-month, 8-month, 12-month, 16-month follow-ups. And the last tip is to always provide treatment X-rays to your patients, because if they wish to go to another dentist and follow up, you can prevent them from taking additional X-rays, or if they want to take a second opinion, they don't have to, the dentist needn't subject them to more X-rays. So always hand over your pre-treatment assessment report with your X-ray, or if you've done your treatment, give them a pre and post-operative X-ray along with your treatment report. So you can help your patients by doing these things.